You able to see the screen? The topic given to me is child post-ventilation psychological aspects of nursing care. I'm working in pediatric intensive care unit, and therefore I thought this will be the important topic because I deal with them day in and out. We all know that children post-ventilation, when they get discharged, they do have some kind of psychological impact. In our PICU, on an average, they stay for 5 to 7 days, and they are on the ventilator for 3 to 5 days. Then they are shifted to the PHDU and then to the ward, and then they are discharged from the ward. So, in my own experience, and generally it's a well-known fact that children do have some kind of psychological kind of stress or impact related to the process of ventilation. So caring for a child post-ventilation can be a challenging and emotionally demanding experience. Both the child and their caregivers may face a range of psychological issues during and after the ventilation process. So I thought I will discuss some of them. We know that children already by themselves have a lot of stress and challenges because of the process of growth and development. A lot of challenges because each stage has its own kind of challenge, and also their systems are immature. All the organ systems are quite immature, and so very easily they get insulted and they can land up with complications and things like that. We know that. So pediatric critical care is the most challenging place for the child and as well for the healthcare professionals, whether it's nurses or the medical team or support team. It's the most critical area, and therefore it's a kind of joint work. And who's important in the team? Definitely the children are the most important one, and all of us are jointly there to help the children come out well so that they will not have any complications and they will have a kind of pleasant hospital experience. And so the children and family will have a positive outlook to the hospital if the nursing care and the entire team coordination is well taken care. So psychological impairment, the primary focus of studies, many studies have been done. I am just quoting 1 or 2 studies only. The study by Dow Kennedy, it says that 6 months after the discharge from PICU, the prevalence of post-traumatic disorder was found to be 17 to 29% for school children and adolescents, which is quite a big number. And in studies examining the reasons for post-traumatic stress, it has been reported that frequently invasive procedures which increases the psychological mobility. All sorts of procedures are being done, the intubation, the PICC lines being introduced, and various kind of investigations that are done. Everything requires an invasive procedure, and therefore it is painful. How much ever the pain team intervenes and it takes care, but there is some kind of psychological impact. So medical fears weaken the sense of their health control, and too many invasive interventions accelerates the progression of traumatic stress disorder symptoms in children. 1/3 of the children survive from a critical illness reported from the memories, and benzodiazepine opiate administration or risk factors for delusional memory. Some of them present with delirium and delusional delusions. So to reduce the prevalence of such risk factors, the PICU team always makes sure that the sedation is evaluated, and it should be age appropriate, it should be patient specific, and because each of them are unique in their own response to the pain med and their reaction to pain as well. And so the pain team in PICU is more sensitive in evaluating the effectiveness of the sedation agents, and that actually has a lot of impact on their after the discharge, how they behave. So moreover, the intensive care environment and density of the intensive procedures that are done can also affect their sleep, not only in ICU, even after they get back home. After the discharge, they do have some complaints like sleep disturbances and mood changes, which are reported by the family post-discharge period. So one of the identified interventions in our PICU team, and I suppose this has been accepted worldwide, is to maintain an intensive care diary. They are accepted as a tool to fill up memory gaps of patients, and they are written prospectively and address the patient's concerns. So they include summary of the admission, narration of daily activities, the transfer notes from ICU, everything what they experience, they put down on the diary and they try to reflect back on. And that actually has a lot of impact on their behavior after the discharge. Entries for the diaries are handled by the bedside nurses. Family narrates the experience of the family members during ICU admission. And also this helps in intervening then and there in case they have some kind of unpleasant experience in the ICU or anything untoward, then they express it then and there and it can be intervened and it can be rectified by doing a risk analysis. It's quite important to be shown positive outcomes of diary that have a common use in adult literature. And it was suggested in the study done by Mickelson that diaries maintained both by the children and family had a role to signify PICU experiences, and use of diaries in the PICU might help children to comprehend their stories in a better way. And another intervention for psychological morbidities of PICS is the group, a group which can be, it can be the parental network. Actually, even after they go back home, we actually have formulated a parental network where they can address these issues, and they themselves rectify many of the problems because of the strong parental group network, which is available in our area, and I'm sure it is available in different parts of the world. So providing some places or planning a schedule for the family members and friends of the patient to support one another and coming together. Post-discharge period also, the survivors, actually the mortality rate in our PICU, it ranges from 8 to 10, and most of them come to us in a very late stage. Either they would have gone to some small clinics. There are well-established centers in our Tamil Nadu. Then there isn't a problem. But if they had gone to a very smaller place where there are antibiotic abuse and even the corticosteroids are not given appropriately, so in such a case they actually land up in a very serious stage, and so the outcome becomes very detrimental or very bad when they approach us very late, especially not having approached well-established centers within our state. So therefore, a structured follow-up program is also essential. We need to follow them up as a physician group or a multidisciplinary team or a nursing group. We have to do prompt follow-up on these children. So it's recommended that they to be followed up, and also caregivers such as the parents or family members often experience a mix of emotions, including fear, anxiety, guilt, helplessness, while the child is on ventilator. And some of them do present with post-traumatic psychological issues, and so it becomes very difficult for them. Child's emotional response. Children who have been on ventilator may experience distress as well, emotional distress, especially if they are old enough to understand what has happened in the unit. All the invasive procedures and the machines that are there definitely causes a lot of fear in them. So fear and anxiety and difficult to cope with is a common kind of thing. And as team members, how can we allay this fear? How can we allay this anxiety? And how can we enable them to cope with, and also the family members to cope with the stress that they undergo? And some of them can even present with nightmares and flashes and persistent anxiety. So communication is one of the important tools which can be used now that we have various tools like we are actually improving on our technology, where children can be made, even if they are on a ventilator, and if they are not, if they are about to be weaned and all, or even children on tracheostomy, we can give them a paper and pencil to write down and things like that. So non-verbal communication can be strongly used in PICU setup. And they should not have fear of medical professionals, whether doctors or supportive staff or nurses. They should never have fear. So all these are the concerns, and I'm sure all of us as health team members, we take a lot of initiative in reducing stress among the children and also among the family members. When while they are in the PICU setup, and we must try all our means, all our best efforts to minimize the post-traumatic stress, and strong parental networking, and forming a strong follow-up program, or after they get discharged. And we can also, we have a lot of NGOs and community-based organizations in our area. Likewise, I'm sure everywhere it is available. So we can put them up with these kind of organizations which can help them financially, or which can help provide other sort of medical help, and so on. So it is the responsibility of the nurses particularly, and of course all the health team members, to minimize the stress that can happen to the children and the family members after they get discharged, especially the post-traumatic stress. Thank you very much for giving me the opportunity to present about the post-ventilation psychological aspects of nursing care. And I thank the team enormously for giving me this opportunity. And I do learn a lot from all the members, all the experts, from their vibrant speeches, because always it's been a learning arena for me, and a lot of take-home messages which I share with my own students. Thank you one and all. Thank you very much.